We welcome you all for the live case from Narayan Hospital, Bangalore. And the primary operator is Dr. Sanjay Mehrotra, who's going to be talking to you in a while. So, again, I would like to thank for giving us this opportunity to present or show a live case. Next slide, please. So this patient is an 83-year-old female, symptomatic severe aortic stenosis, NYHA class 3-4, has a history of hypothyroidism, history of renal disease, creatinine of 2.5 has come down to 1.9 as of now, EF of 30%, atrial fibrillation, left bundle branch block, diabetes, and STS score of 11. You clearly see this is a true high-risk case. Next slide, please. Next slide. These are the echo parameters. The peak gradient is 61, mean gradient is 35 millimeters of mercury with low EF, orifice area of 0.8, EF of 30%. Next slide, please. Next slide. So the CT scan assessment gives us an area of 366, and this patient qualifies for a 23 millimeter valve. A 23 millimeter valve is 12% oversized compared to the annulus. Next slide, please. Next slide. Next slide. Next slide. So we have selected a 23 millimeter valve. 23 millimeter valve, as of now, it's going to go through a 22 French sheath. Next slide, please. CT scan assessments. Not much of calcium on the leaflet. Next slide, please. Next slide. Next slide. Next slide. Yeah. So now maybe we can go live. What we have done is we have taken a 6 French axis on the right common femoral artery, and we've taken and put a 3 proglides on the left side, upsized the left axis to an 18 French sheath. We've crossed the valve using a AR catheter, and we'll be showing you the hemodynamics here.
Okay, so we can go live now.
Both like the same range, not much of gradient, but the patient had a big.
Okay.
Yeah, okay, fine. Fine, I can hear myself. So, hello, hi everybody. My name is Dr. Sanjay Mehrotra. Ravinder has already explained you the details about the patient. She has significant aortic stenosis but low EF, but right now I don't see much of a gradient in this patient. Two concerns doing this valve. One is, of course, the entry vascular access.
We don't do pre-dilatation.
And now we are ready for the pre-dilatation. Initially, we were planning we'll not do a pre-dilatation. I would leave most of the communication to be done by Ravindra because I want to concentrate on patients. So I may be talking less. You guys can ask questions from Ravindra.
I totally understand and appreciate.
What do you think about pre-dilatation?
Can I have the super stiff wire?
Should we do a
Super stiff wire. We need to shape the wire.
So Ravinder, while you're setting up for pre-dil,
the groin. This lady has a femoral artery.
Go ahead.
Can you repeat that question?
Go ahead, proceed. We don't want to interfere. Go ahead.
Yeah. So, initially we were planning not to pre-dilate this patient, pre-dilate the valve, but the concern here is, as of now, this valve will be going through a 22 French sheath. And the femoral artery on the left side is 7.2. The external iliac artery minimal diameter is around 7.4. So if you look at the 22 French sheath, its OD is almost 24 French. And we will be stretching this 7.4 millimeter vessel up till 8 millimeter vessel. So what we have done here as of now is we have an 18 French sheath in place. We have crossed the valve with the catheter. We'll be putting our Emplas extra stiff wire in the LV. And with that wire, over that wire, we'll try to advance our 22 French sheath. Now, we might face difficulty because the sheath might not go all the way up till the abdominal or the infrarenal aorta because of borderline or small size vessels in the external iliac or the common femoral artery. Our idea is we'll try to enter as much as we can go and then try to advance the valve. So my question is, maybe I would like to have an input from you, Dr. Parikh. What do you think about, should we go pre-dilate this balloon valve or not? You look at the gradients, hemodynamic gradients, are they visible to you on the screen?
Yeah, we initially saw them, Ravinder, and we were going to ask
Can somebody
you.
show the gradients?
We see him now, yes.
Yeah.
Uh, Can you
Yeah.
explain to us, and again,
Yeah.
for our
So
audience,
I
how do you decide to even take on a case like this? Again, we know that we have low ejection fraction. How did you decide that this was a severe AS
the
case,
fir-
despite the low gradient at the present time?
3 episodes of pulmonary edema, heart
yeah,
failure
yeah.
3 times in the last.
So the
1 year.
important question is, whenever a patient has a low gradient aortic
What do you think,
stenosis.
Ravindra? Is
Yeah,
this okay?
This looks good.
This looks good.
This looks good.
Are we okay to go in
Yeah,
with this?
yeah. Let's go ahead and
So
place
that's
this wire in
just
the
the
LV.
shape of the wire, which is important to be. That looks like it is not traumatic now. Of course, this is the usual technique which we use for most of the patients.
We'll go with
So
the
I want
valve.
to change it to a pigtail now. Pigtail is not in. Okay, I want a regular wire.
So
Come to RAO, please.
regular exchange length wire. So let me
Regular
expl-
exchange length wire.
So let me answer that question which Dr. Parikh had asked, how do we evaluate a patient with aortic stenosis and low gradients? We need to differentiate between true aortic stenosis and pseudo-aortic stenosis. The way we do is, and
Sure.
the way everybody does is, or it's recommended is, we do a low-dose dobutamine stress echo and document whether there is an increase in, is there a contractile reserve? Is it a true aortic stenosis or not? If the patient's gradient go above, mean goes above 40 millimeters of mercury, and the aortic valve area remains same or goes down, that means patient
You
has
come
true
this
aortic
side. Remove
stenosis
this,
with
keep the
contractile
wire
reserve.
inside.
Now you can see on the screen here, Dr. Mehrotra has placed a regular wire in the LV. Over the regular wire, we'll be putting a pigtail in the
Pigtail.
LV. Let's get a pigtail, please. This is more of a safer approach. Pigtail, please. Pigtail.
Pigtail catheter.
So you
Inside
have
a pigtail catheter will position
yeah,
our
yeah,
M-plus
yeah.
extra stiff wire
Okay.
and prevent.
So just for purposes of our audience,
Sorry, say that
Ravinder,
again.
just if you don't mind, I just want to keep to the basics. That was a beautiful explanation of low output AS and how you decide. For arterial and venous access, you have currently 6 French femoral arterial access. You have a 21 French on the left femoral artery, and you have a venous
Yes.
access with a TVP, correct?
18 French on the left femoral artery.
18 French, okay.
Yes.
The arteries don't look very good.
Yeah.
So that's the biggest concern we have. Don't
Yeah.
pull the wire, please. Don't pull the wire. Keep the wire. Now fix the wire on the table.
So and the pressure measurements is what we did from the pigtail in the ascending aorta and our M-plus
Deep.
catheter in the LV.
Okay, hold the wire tight.
So here you
leave
can
it
now
now.
see the pigtail is
And are you
in the
using
LV
general
with a catheter to
anesthesia
the
here, or is the
apex.
patient awake?
I'll push the pigtail down to the apex. So
No,
this
it's
we're doing this
local.
patient the conscious sedation because she's high risk for general anesthesia as well, but we have a cardiac anesthetist in the room. Presently we are doing under conscious sedation.
Very good.
That's not very good. Can I have the super stiff wire for a second? This is not good.
I think it's caught somewhere in the
cord.
yeah. Cord. What we can do is we can just push the pigtail without a wire.
Yeah, and then see.
It's not going. Yeah, let's just push the pigtail without a wire. Yeah, just push
Yeah,
the
that's
pigtail.
better. It's letting go.
Yeah, you're caught up on a pap muscle.
I think we haven't reached the apex yet. Yeah, looks like it is caught up on a somewhere either in the papillary muscles or somewhere.
Do
Let
we
us
have
try
to cross again?
You think so? Maybe we can try to push it to the apex. Just push the pigtail.
Yeah, that's
Now
better.
this is
That's
much
better.
better. Much better. Yeah. Nice. Good.
Yeah.
All right. Now you can see the pigtail has been positioned to the apex in the RAO view. We'll try to stay fire, please.
Now stiff wire.
Any comments from you, Dr. Parekh?
No, we're watching you work.
The other question which I would, okay, yeah. The other thing, we were discussing about low gradient aortic stenosis. Now again, if patient has a low gradient aortic stenosis and normal EF, the first thing which you want to look at in that patient is his blood pressure. If his systemic blood pressure is more than 160, what you want to do is you want to treat the hypertension, bring the systolic blood pressure to below 140,
Come this side.
call the patient
Screen.
again in your echo lab or maybe in your outpatient clinic and reassess the gradients again. Now you can see here in this patient, particularly her systolic blood pressure is almost 190. Maybe we can treat it a little better to bring the blood pressure down. Yeah. So this is another way to assess when you're looking for a paradoxical low flow, low gradient severe aortic stenosis with high blood pressure. So you can see the wire is placed. What we'll do now is we'll take a 16, yeah? Yeah.
16 balloon.
16 balloon, please.
Come this side.
Yeah. Yeah, okay.
Can you just give me the flush?
So this is a mammoth balloon.
Larger flush, larger flush. I want to flush the 20 cc flush.
Okay.
Just 1 second, huh? The
Yeah,
wire
sure.
is left empty.
This is the inflation.
Okay, go ahead.
Go ahead.
Yeah, so we need to be pacing the patient at 150.
Yeah, 150, 160 is fine. Hold the wire.
You're
Let's
holding
go.
the wire?
Yeah.
Okay, come to
Hold the
LAO.
wire. LAO, please.
LAO 30, the LAO 15, which was showing the coplanar view. Yeah, center please, center now.
Okay.
Just follow the
Hold the wire.
valve.
Hold the wire. Just look at the wire in the chick.
Just see the wire.
on the
See
screen.
the wire. See
Yeah,
the wire.
yeah.
See the wire top end.
Okay.
Okay, we're ready to pace in now.
Yeah.
Ravinder, you will dilate.
Yeah, I'll dilate.
Okay.
That's fine. Go ahead.
So pace the patient at 150 now.
let's-
We'll be
let's-
pacing. Pressure would be down.
Fluoro.
1 second.
Fluoro. Not yet. We're going to ask you to pace. We'll ask you to pace.
Don't pace now.
Let's go into the LV. Okay. All right. Pace at 160.
Pace at 160.
Pace, please.
Pace, please. See the pressure.
160. Pace, please. Okay. We'll go ahead and
Yep.
inflate here. Deflate. Stop pacing.
Stop pacing.
Fluoro. Leave it high.
You can, wire, just push the wire a bit. Yeah.
Yeah.
It's not
Okay.
deflated completely.
Yeah.
The wire is it
Hold
bit
the wire.
out.
Hold the
Hold
wire.
the wire.
I think we're fine. Okay.
Stop
what are you gonna
pacing.
do? That's fine. Leave it. Leave it. Yeah.
It's a bit hard.
Yeah.
So
So we did that pre-dilatation, and now we're gonna go with we'll put our 22 French sheath.
Barely a pre-dose.
almost out. Out.
Okay. All right. Let's
You
get the
can
sheath
pull
in
the
front.
balloon out.
Yeah. Go to 48 mag now. Show us the wire in the LV, and we would like to see the sheath
Less
as it
mag
goes up.
now. Less mag now. Come. You can come to AP if you want. We'll go back to that coplanar.
So
view.
Ravinder, we have a question
Yep.
here is
And I want to see both the
Um,
places.
how do you know that you've done an adequate pre-dill in
Yeah.
these types of cases for a balloon expandable TAVR system?
So what we did is we just
So
used a
come
16
hold
mm
this.
balloon.
Hold this.
Yeah. And the idea to do a pre-dill is to make
You're
enough
ready with the
space.
sheath?
To make enough space so that the valve enters without much resistance. What sometimes happens is
It'll bleed.
sometimes the effective orifice area is so small that the valve is not able to enter into the LV, and at that point of time we are pushing on the catheter and kind of doing various other maneuvers to get into the LV. In this particular patient, initially we were planning to do not to do a pre-dilatation, but the concern was what if our sheath is we are not able to advance our sheath all the
So
way
come
up to
down now, please.
iliacs. Now you can see the sheath is being advanced.
Come down now.
Yeah, fluoro.
Fluoro.
Yeah. Okay. Show us the apex now. Show us the wire in the heart.
Apex now.
Show us the wire in the LV, please. So this is important. We need to see both.
Yeah,
Yeah,
show
let
down.
us- Yeah, let us try to go. So you can see,
You can stop there.
yeah,
Yeah.
do you feel a lot of resistance?
Lot of resistance.
Show us the wire in the LV. So what we'll do is, I think if,
We'll stop here.
yeah, you think so?
Yeah.
So this is what we were anticipating, you know.
Sure.
We
Come down.
Show us down. We're not able to advance our sheath all the way up till the
We'll
abdominal aorta, and we don't want to do too much of pushing and pulling. Do you want to try a little bit more? Maybe some jiggle
You've
movement.
already gone up to the iliac
Yeah, yeah.
crest, you see.
But do you think it's not going to go further?
No, I'm going
No?
to worry about it now.
All right, sure.
So we'll work from here.
Yeah. What we'll do is show us the wire and the LV. All we need to look at the wire and the LV. We'll try to remove the dilator from here.
Yeah.
Okay.
So you do
Yeah.
it.
Yeah. Okay. And then what we'll do is,
I'm holding the sheet.
yeah, and then you'll have to close it. Somebody will have to hold the sheet all the time.
I'm holding.
Yeah,
I'm
okay,
holding.
Okay. And then you ready? Not
Yeah.
yet. Not yet. Not yet. Not yet. Okay. Close that. Okay. So what we have done is we have advanced the
Now
sheet.
show the tip. Is
Tip
the
of the sheet.
tip of the sheet is visible? Show. Down. Yeah, we are in.
So let us.
We're good. That's good enough. We'll not go more than that.
So this is because the Python sheet, 14 French sheet, which I talked about which I talked in the
So
talk.
we are okay now
Yeah.
at the lower end. We just have to push
Let's
the
have the
valve
valve in
now.
place. Let's do a fluoro.
So now we again have to confirm two things. Raju and company, please listen to me. I want full concentration, no talking in between. The steps are following. The pigtail has to be positioned. This valve would be advanced now through the sheath. It'll go right into the ascending aorta. When we go into the ventricle, our coplanar view would be in position. So we have to go to LAO 15 that was showing all the things in the same plane. Then we will cross the valve. We will understand our position. And then once we are okay with the position, we will be inflating the valve under pacing. It is important to understand how we will pace. We will pace the patient at 160 to bring the pressure down to less than 70. At that time, we would be deploying the valve initially partially. The pacing will continue. You will not do anything to the pacing unless we say stop pacing. Once we have understood our deployment is correct, then we will go full deployment, which is what we call as committing of the valve deployment. After the valve is deployed, we'll deflate the balloon. Mind you, pacing will continue. Once the balloon is deflated completely, then we will say stop pacing. It's very important, don't stop pacing. If there is any loss of pacing in between, Patil, Vijay, you have to make sure that the wire goes in. What happens sometimes is that when the patient drops the pressure, there is a movement of the patient. So you need to make sure the legs don't move, otherwise things get pulled out, right? So we're ready.
All right, so we'll do a fluoro check of the valve. Let us see how it is loaded.
It's loaded.
Okay, mag up, please.
Mag more. Mag more. Mag more.
So now you can see 3 dots here, one right in the center and 2 on the ends. All right. I think
We
it's
see that
good.
very nicely.
And
Valve
on
is
the-
loaded correctly.
Yeah, and on the external, what we confirm is this is the outer buffing skirt. It
Yeah,
has
so
to
we
be
can see it.
ventricular.
Yeah,
It
yeah.
is ventricular.
Ventricular. Right. got
Just
it.
just
So
before
that's
you
important
start,
point.
can you
This is something which we wanted to show. There's an outer skirt which has to be towards the ventricle.
We see
Yeah,
it very
It
nicely.
may not be visible, but that's fine. Let's go ahead.
Okay. Okay. Who's on the injector? Is the injector ready?
Injector ready? We'll be connecting. Wait, we have time.
Yeah. Yeah.
We have time. We'll connect. Let's go in first.
Okay. So.
So now we have to pull.
Okay, that's fine. So what do you have to do? I don't have the
So-
wire yet. Let us
Yeah.
see. Okay.
You got
So
the wire?
Yeah. So what you have to do is
Let's see the pigtail inside
show
the
us the
LV.
wire. That's it. Show us the wire in the LV.
LV wire.
Go 48 mag.
Yeah, that's good.
Good.
Less mag.
So wire.
Now we
is
have to
very
release this
important,
again,
right? Okay. So yeah, you'll have to release this. Release it fully.
You have to just.
Yeah.
That's it.
Okay. Lock it a little. But now you try to go in. That's good. So don't even lock it. Just go.
Okay. Let me see it now. Down.
Show us down.
Down. Down.
Okay. Can you push it? If you're
No,
not
I'm
able
going
to push
in.
it,
I'm
yeah,
going. I'm
yeah.
going.
You can unlock it again if
No, it's going.
that's good. Okay. Okay. Now show us the wire there. Wire above.
It's a bit tough there.
Nice. Show us the wire in the LV. Good. Nice.
Some resistance.
Okay.
A lot of resistance, which I had to
Let's
do.
go. Now let's put our pigtail in position.
Yeah. And now we connect to the ventricle.
So here you can see the navigator catheter. You can
Flush,
flex-
please. There would be some resistance going. You might have to use the navigator
So
catheter.
what we can do is we can connect the blood
Okay,
pressure to
connect-
the side arm of the sheath.
Yeah, you can do that.
I'll have some blood pressure.
And I want the wire now to go into the root of the... I think we are already there.
Yeah.
Okay. Can I have a bit of contrast in my hand? Go, Elio. Go, Elio. Elio, please, same Elio, which is the co-planar view. Zoom now. Zoom now.
Zoom. Mag up.
Mag up. Mag up. Mag up. More.
More. Good.
More.
This is good. Yeah.
Okay. Just one acquisition,
Yeah.
small. It's a bit
What is the
quarter.
view?
Go a
Yeah.
bit quarter. Just a bit
Quarter.
quarter. One more time,
Yeah,
small
yeah.
puff.
So let's go ahead. We're confirming our coplanar view. We took an aerogram.
That looks good to me.
I think that looks good.
Yeah.
What do you think, Dr. Parekh, there?
Can I have the connection now of the
Yeah,
injector
no, we
now?
all agree this is a good view for
It should come
placement.
below everything. You just take it below.
This looks better. So this is very important for us.
Okay, push, push.
Need to identify
Push,
a
push,
coplanar
push.
view. You can see the pigtail in non-coronary sinus,
Suck.
and all three of them are in the straight line.
Suck, please.
All right, so we are ready. What I've done is that this is a
Suck,
navigated
please.
catheter.
Take it back in,
where
take it
we
back
can-
in, take it back in, take it fully back in. Okay, now push it
Okay.
back. Push it back. Empty the catheter from the blood. How much heparin was given? 5,000. Okay, we're okay.
Our
Empty-
target ACD is 300 for these
So
cases.
now you would be moving and I would
Yeah.
be advancing.
Yeah,
Is that right?
Let's go ahead.
Yeah. So I'm advancing
Yeah.
this.
Show us the
Show
arch.
the arch, please, now. Arch. Concentrate, huh?
Go ahead. Leave the wire. Leave the wire.
Leave the wire. Don't touch the wire. You control the wire. Bit of resistance
Okay.
there.
So what we'll do is we'll come back again. Maybe we'll give more torque here. So you can see here how the valve has caught, the whole system has caught onto the catheter there. We'll torque it more. So this is the navigator catheter. Let us try to go in now. Now, let's be careful with the wire. Okay, let's try to go in.
My hands are
No,
slipping.
okay. So give me 1 minute here. Let's come out, let's come back again.
Wire. Just
Yeah.
push the wire a bit.
Yeah. Gonna
No,
do
no,
is
don't.
we'll
don't.
torque it
I don't
more.
want wet. I want dry because my hands are slipping.
Okay, let's try to go in again. Maybe what we can do is let's fluoro. Let's go now. Yeah, it was caught onto the pigtail, so we'll advance the pigtail now
Pigtail
back
now.
again.
Yeah, I
so
see
I'll put
that.
the
That
pigtail
was-
back. Now let's go with the pigtail. Yeah.
Yeah, that's good.
Okay.
We
let's
may
go
have to
in.
see the clopanner one more time, but we'll.
I think we should be fine.
We should
We
be
are
fine.
still in the same view. We'll take a
Okay.
picture once we cross the valve.
Okay.
Let us try to cross the LV. Let's go in. Let's go. Okay. Let's enter. Okay. Easy, 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 easy. So hold the sheet there. Somebody hold the sheet. Just
come out.
put some pressure. Put some pressure on the sheet. Put some pressure.
The sheet came out.
Put some pressure. That's fine. Let us try to do one thing. Let's try to push this thing. Somebody hold the pressure.
Pressure.
Hold the wire.
You push it now.
Yeah, hold the wire. Okay, so we got in.
Yeah.
Okay, somebody hold pressure there. So we should be fine. Leave the wire. Leave the
Leave
wire.
the wire. Leave the wire.
Yeah.
We'll
Do-
just pull it back
Okay.
a bit.
Do you have pressures on the screen, please? Somebody has pressure.
Pressure on the screen? How much
Yeah.
is the pressure?
How much is there? How much is the
Please
pressure?
tell the pressure.
Right, so let us go in a little. Let's go in a little here. So I think
Yeah.
we'll take a picture here. Let's go in.
Okay, you're ready with the
Yeah.
picture?
Picture. Cine. Inject.
Inject.
I think we go in a little bit in. I think we should be fine. Just a little bit in. Fluoro, 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 fluoro. And this should be good. Let's take one final picture. Inject. I think this looks good to
Looks
me.
look good.
What do you think, Sanjeev?
Yeah, that looks good to me.
Okay, so fluoro. You hold the valve.
Yeah.
Okay, begin pacing at 160. Where's the
160?
pressures?
Tell us the pressure.
Okay. 160, please. Okay. Okay. They're going too deep. Good, good, good. 1001, 1002,
1003,
1003, 1004. Deflate.
Don't
Don't do
stop.
anything. Don't do anything. All right. Stop pacing now.
Stop pacing now.
Okay. Let's remove the balloon.
Yeah, you have
Yeah.
to push in the wire. There's a bit
Okay.
of bleeding here,
Okay.
so don't
Hold
worry.
some pressure. Hold some.
Right,
That's
right.
fine. That's okay. That's fine.
Sheath came in.
Okay. Let's remove the. Yeah. Yeah. Give me 1 minute. 1 minute.
Yeah, we're fine. We're fine. Just advance this.
1 second. 1 second here. Okay. We'll take one final picture.
Yeah, we
Wire
don't see
is
the
hitting
pressure
the-
on the
That's good.
hemodynamics.
That's fine. That's fine. We just okay. Yeah. We'll just
wait.
get the. We
What's
lost
the pressure now? How much the pressure?
Show us the pressure on the hemodynamics, please. Show us the pressure.
We're going to have to
lost
connect
the
it.
screen.
Yeah,
All right.
that's
We'll
right.
do one.
Huh?
Okay.
That's
All
fine.
right, we'll do an autogram here. Our pressure is 180/75. Fluoro.
1 second.
Okay, let's take a picture here. Show us the LV. Inject. Inject
Inject.
now.
That's good.
I think that looks good. That's a
looks
good
good.
deployment, I believe.
A very nice.
I don't
done.
see
Coronaries are
much-
filling.
yeah.
Nothing needs to be
So
done.
we have a small issue here. We have some issue with the groin.
I think
Our
we can
sheath-
sell it.
Our
We
sheath
can
has
do
come
it.
out.
We
So
can-
what we'll do, we'll try to fix that first. I think we'll focus on that deploying a pro glide here.
Hmm.
And I think what you saw is our valve dived in a little, and that is the importance of slow inflation. We inflated slowly. At that point of time, what we
I
saw is
pulled it
that
back
yeah,
here.
the valve was into the LV. We took our time, pulled it back just a
leave it,
little,
leave.
and did the final inflation. I just pull up pro glides.
Yeah.
Yeah.
So we'll just pull out the Pro Glide a bit
I think
more.
so. What we'll do?
Yeah, we'll remove. No, it's
We'll
fine.
remove this.
You remove the whole thing.
Yeah, I think
leave
I'll
the
do
wire
that.
inside.
Yeah. We'll
Leave the wire inside.
Yeah, it's deflex. So what we're going to do is we're going to leave the wire.
It's okay. It's
inside.
okay. Don't worry. Just remove that. Yeah, that's it.
Yeah.
Oh, the wire also
The
came
wires
out.
come out.
Oh,
Just take your time. Take your time. I think what we're going to do is, which is your first pro glide. Let us deploy the pro glide first.
I think wire
Go
was
ahead, go ahead,
important. Yeah.
Somebody go there. Show us the previous
Now,
picture.
We need to put one more. Pro Glide is lost. The wire is lost there. So
Wire
it's a problem.
is Yeah. Pro glide is lost.
No, wire is lost now, so we can't put the Pro
Yeah,
Glide
yeah,
there.
that's okay. Do you want to deploy one? Just
I have
deploy
already deployed
one.
one.
That's
yeah.
good. We'll wait. Just hold some pressure. Above.
We may
What
have
we'll
to-
do is we'll reverse the protamine, please. Yeah. Hold some pressure. Above. So leave
It's okay. I'm holding. Don't worry. So
Show
we
us
lost
the picture.
wire.
Scene minus. Scene minus. I think this is a problem
Okay,
that's
just
going to be
hold on,
there
hold
until
on.
we are using 22 French
Hold on.
system. But I think we
Give me a-
have deployed a
let's see.
ProGlide and we have achieved hemostasis on the groin. Show us the blood pressure, please. Can somebody focus on the blood pressure? Camera? Good.
Okay, let me handle it. Let me
Camera,
handle
show
it.
us the hemodynamics on the screen.
No, we can't do anything about it. No.
Just hold some pressure, hold some pressure.
We need to just press and get the vascular surgeon to do it maybe. We'll go from the other side,
Yeah.
maybe occlude for some time. 'Cause what happened? We lost the wire.
Yeah, the wire won't come out actually. The wire won't come out from this.
Oh, that's a problem. Huh?
So what we'll do is just show us the hemodynamics, yeah.
Don't worry.
So you
don't
can see
worry.
the blood pressure is good. In fact, 200 by 94. Heart rate is 100. Saturation is good.
Fine.
Patient is fully. And I
Patient's
don't see
okay?
any other comfortable. And what we'll do is we'll show you the echo also. Let us focus on the cine fluoro.
Can we
Scene
reduce
minus.
the
Can somebody
pressure a
play the
bit?
previous picture? Scene minus. So let's get the blood pressure down. Let's give protamine.
So we need to probably go from the other side and maybe put a covered stent. That's it.
I think you're right. I mean, this is going to be a challenge until we have our 14 French keys in
No, we
place.
don't have the
Yeah,
wire now,
yeah,
no?
yeah,
so we
yeah,
can't puncture
yeah,
the same
yeah,
thing.
that's
It's impossible.
Play the picture on the
So
fluoroscopy.
yeah.
Scene minus.
No, it's
Scene
so
minus,
good.
please.
Don't talk right now. I can't do anything about it.
Scene minus. Scene minus.
I'll handle it.
Yeah. Okay, next. Okay.
Table down, please.
Just show the last picture. Table down. I think that's a good aortogram. We just see a whiff
So
of
give a call
contrast.
to Raghu.
I think we are
We're
done,
okay. We're okay.
right?
Yeah.
Very nicely done.
And thank you very much for Mehrotra Life Sciences for having us here.
We'll
Thank
let
you,
you
Dr. Pai.
focus on the
So
groin
hematoma.
now.
We'll
It's
give you
beautiful
a final
demonstration,
update once
Ravinder,
we fix the groin.
and we appreciate it very
Yeah,
much,
sure.
and we'll talk to you soon.
Thank you so much.
There's a hematoma.
Yeah.
Thank you. So what we do is that somebody can just see what's happening.
So they're going
So I
to
want some
focus
pressure
on
on that.
closing
You will
this
press it.
All right. Thank you so much.
18 French groin.
Hematoma, big hematoma.
Dr. Rao, welcome back, and share with us how you finished the case.
Yes, Dr. Parikh, I can hear you. Yeah.
Yes, we hear you.
So we called in our vascular surgeons. We called for help. We went from, yeah. Can you hear us? So what we did is the sheath on the left side was a 22 French sheath. It actually came out and there was some hematoma going on. We deployed our proglides immediately once the valve was deployed. However, still there was some bleeding. So we went from the right side, did a balloon tamponade, and the vascular surgeon has opened up the groin and they are repairing the common femoral artery by surgical. What I'll do is, patient is stable. I'll share with the post-procedure echo images with you. Can you see the echo, Dr. Parikh?
We do see it, yes.
Can you see the 2D echo images?
Yes, we see it.
Okay. So, all right, let us show. You can see this is poor. Yeah. Okay. Let's go to the next one. Show us a 4-chamber view and yeah, open that. No, it's not coming up. So this is a 4-chamber view. You can clearly see poor LV dysfunction and the RV has collapsed, and that is because we lost some blood and definitely indicates hypovolemia. You can see those valve frames valve sitting nicely there, and show us the last gradients. Show us the gradients, please. I'm going to share whatever images we were able to obtain, the gradients. This is the final post-procedure gradient. You can see the velocity is 1.15 meter per second, peak gradient of 5.26, no aortic regurgitation, and properly functioning valve. This is all I would like to share, and I would like to thank again. And if any questions, anything from your side, Dr. Parikh. So echo shows good functioning of the transcatheter valve, no AI, mean gradients in single digits, and the vascular repair process is ongoing there. We have 2 vascular surgeons repairing the groin.
So Dr. Rao, thank you very much for sharing this technically very challenging and quite ill
Thank you
patient
so much.
with
Thank
us.
you. Thank you.
I think that it points out to everybody that the procedure is multifaceted. It's really a collaborative team approach. And I think the vascular access parts of this are similar to what we face in the United States as well, where very often we will have surgical colleagues helping us in order to complete the case.
I totally agree with you. It's more of a team approach. You need to have a surgeon, a cardiologist, an imaging guy, and a good anesthetist in the room.
Very good. Any questions for Dr. Rao?
Thank you so much.
Okay. Have a nice day, Dr. Rao. Congratulate your team. Thank you very much.
Thank you so much. Thank you so much. Thank you for giving us an opportunity. You guys, everybody, enjoy the conference, and thank you so much.